And with that said, I'd like to introduce Dr. Pocinki as our first speaker. And he went to Cornell Medical School and got his residency from the Washington Hospital Center. He's one of the top docs in our area. He's so well respected by all of us patients and colleagues alike. He treats a wide array of medical conditions and zebras like us with multi-systemic issues, so we're so lucky to have him. He listens wonderful, he's a great troubleshooter, he truly cares about each and every one of us. So we're so grateful to have him here today. And with that said, unfortunately, Dr. Pocinki, he's not able to take new patients at this time. However, that's why we're grateful to have him here today. So he's going to be talking about the basic concepts of the cycle of chronic pain, poor sleep, fatigue, depression, and EDS, and also touch on autonomic dysfunction and how that relates to EDS as well. And if you have any questions regarding the general topics of discussion, please feel free to ask those. Dr. Pocinki is just not able to answer or give any personal medical advice while he's here during the discussion. So with that, I'm going to let Dr. Pocinki proceed. Go ahead.
Thank you. Hi, Bruce. Thanks for inviting me. It's very warm in here, so I won't be offended if start feeling things off. And you get a little lightheaded if your neighbors will mind to put their feet up on their laps. Or if you just lie down for a minute on the floor. I don't remember it was very warm here, but not quite this warm. Yes, it's a tall word to cover a lot of stuff, so I'm going to try to sort of give you a framework and not go into a whole lot of detail. Hopefully help you fit some pieces together and sort of how I put together a game plan and managing these complicated animals where it always seems like fixing one thing makes two other things worse. So I don't know how relevant this is for this crowd, but I don't get any money from anybody, so that's my patience. I will discuss some off-label medications as opposed to written medications that are approved for any of the things that were in the document. So this is the basic concept, and you could sort of rearrange this however you like and put any of these probably in the center, but the big pain is what drives the rest of these things in these syndromes. And I remember years ago when the first Ehlers-Danlos meeting I went to, and Harley gave an overview of the syndrome, and he went over the symptoms, and he said the number one symptom is pain. And of course, it's pretty obvious why people are in pain. The number two symptom was fatigue. And he said, well, we're not really sure why fatigue is such a prevalent problem. And I sat there thinking, well, I know why fatigue is such a problem, because people don't sleep well. Besides the fact that they're in chronic pain. So, and of course, if you're exhausted and in pain and don't sleep well, you tend to be depressed, and depression tends to make your sleep worse and tends to make you more sensitive to pain, and all these pieces intertwine. Just happened to come across this quote a couple years ago from an international pain conference, which made me feel good that at least I wasn't the only person thinking that patients in pain get sleep disorders, pain makes sleep worse, poor sleep makes pain worse. I'm not so sure that poor sleep and depression is independently associated with pain. I think they're pretty codependent, actually. So the real trick to breaking the cycle is to address all the pieces. If you get somebody pain under control, but they're depressed, then it's going to be hard to get their pain completely under control. As long as you're in pain, depression, and fatigue are not going to get better, sleep's not going to get better, as long as you're depressed, you're still going to be in pain and tired all the time. So you really need to look at all these pieces. Now, you're not going to, throw somebody out with 6 or 8 new medications, each one of which is aimed at trying to treat one of these things. But you need to keep in the back of your mind how all these pieces affect each other. And of course, there is no magic formula that's going to work for everybody. That's the struggle we all face. No two patients in this field have the same symptoms, and even if you do have the same symptoms as somebody else, how your body responds to those symptoms may be different. How you respond to the medications you might use to treat those symptoms is going to be different. It's going to depend on what's going on in your life at the time, what your health was like before you got sick, other medical conditions you might have that are going to interact with trying to treat these. And something I have a strong interest in that is pharmacogenetics, how different people metabolize medications differently. But there are lots of other genetic factors. So I think it goes without saying that everybody requires an individualized plan. This, of course, flies in the face of the trends in modern medicine toward evidence-based medicine and clinical practice guidelines and treating everybody according to the cookbook. You guys, I think you know, are the outliers who don't follow the rules. So, very basically, how do we go about addressing pain? Well, first and foremost, we say, okay, what kind of pain is somebody dealing with? I find it helpful to look at major categories of pain as being inflammatory pain, mechanical pain, and neuropathic pain. So, a lot of pain comes from muscles and joints. The loose joints obviously slide around. That puts strain on the muscles around the joints, trying to hold them together. Those strained muscles, they become inflamed, and that's the inflammatory component of pain. Chronic strain causes the muscles to tighten up, and that chronic pulling, like in the neck, that chronic tightness pulling on things that don't like being pulled on, is what I call mechanical pain. And then there are several different types of neuropathic pain, from the pressure of a disc on a nerve root to what we call allodynia, where the sensitivity to light touch becomes painful. Similarly, visceral pain, such as abdominal pain, can be inflammatory, in the case of colitis or gastritis or something like that. Can be mechanical, which usually means an increase in pressure. That's what you're sensitive to in your abdomen. So typically chronic constipation or lots of gas causes an increase in abdominal pressure, and that's painful. There are some neuropathic abdominal pain syndromes, and then rarely you can have pain from lack of blood flow, which is some kind of compromised blood flow. Headache is almost an independent thing. Several years ago on the national conferences, a few of us sat down and tried to list all the different types of headaches that Ehlers-Danlos patients are predisposed to. I think I got 16, but some other people got closer to 18 or 20. So it's very tricky to get people's headaches under control, because you may get one kind and several other kinds still persist. In addition to inflammatory, mechanic, neuropathic, and vascular headaches, there are also headaches related to cerebrospinal fluid flow, increased intracranial pressure. That's obviously something that you don't see with other types of pain. So you'll recognize a trend here. The most important thing in treating pain is don't underestimate it. So this is a problem that is, again, kind of flips on its head when you read the newspapers every day about people getting overprescribed painkillers. When I explain to people that I have exactly the opposite problem, that I see people in pain who don't want to take pain medicine, or say things like, gee, the pain's not that bad, I'm used to it, I can put up with it, I don't want to take a lot of pain medication. That's really not helpful, as you say later, that leaving your pain undertreated, predisposed to depression, makes you tired, disrupts your sleep, just wears you down. And of course, there are non-pharmacologic pain management approaches to pain too, not just like you've got pills. And then depression, very similar thing. It's okay, different people have different symptoms of depression. What I find helpful is to look at different symptoms as reflecting problems with different major neurotransmitters in the brain. So some people have predominantly serotonergic symptoms, and it's in the next slide. I'll break these down a little bit. So this is something I borrowed from a, let's see, let me just do it. Is that easier, or is it better for me to use the cursor? I don't know. Here's the cursor. I like cursor?
You're right.
The pointer is quite easier for me. So when you're low in serotonin, and we know that chronic pain depletes serotonin. If you're low in serotonin, you worry, you're irritable, you're anxious, you're easily upset. If you're low in norepinephrine is a close cousin of adrenaline. If you've been cranking out adrenaline, trying to keep going for years, you're going to be low in norepinephrine. The symptoms of norepinephrine are ones that a lot of Ehlers-Danlos patients are familiar with. Fatigue, trouble concentrating, there's an increased sensitivity to pain. And then if you're low on dopamine, you don't have no motivation, you don't feel like doing anything. Like, okay, I'm less depressed, but I'm still blah, not really fun, I'm not looking forward to anything. And different people obviously have different symptoms or combinations of these symptoms. So again, same principle as pain. Saying, yeah, of course I'm depressed, because wouldn't you be depressed too? I've been sick, nobody can tell me what's wrong with me. I can't do all the things I used to be able to do. Well, yeah, it's normal to be depressed, but that doesn't mean we should do something about it.